Here we'll look at ultrafiltration or fluid exchange across capillaries, which is driven by the Starling forces. So the exchange of fluid across capillary walls is known as ultrafiltration. And the process of ultrafiltration is driven by hydrostatic and osmotic pressure gradients between the inside of the capillary and the interstitium. The hydrostatic pressure inside the capillary favors filtration, driving fluid out of the capillary, while the hydrostatic pressure in the interstitial fluid pushes back, opposing filtration. And the effective osmotic pressure here is based on protein concentration of each compartment, which is known as the colloid osmotic pressure or the oncotic pressure. Plasma proteins present in the capillary provide a force that opposes filtration, while proteins in the interstitial fluid, which are few under normal circumstances, pull fluid out of the capillary. And it's really a balance of these Starling forces, some that favor filtration and some that oppose filtration, that determine the net filtration that occurs. So ultrafiltration is driven by the pressure gradients. Now we'll look at what those gradients actually look like in most capillary beds. So this simplified image here is of a vessel, but really represents this entire capillary bed with an arterial end that receives blood from the arterioles. The blood flows through the capillaries, encountering some resistance, and then it reaches the venous end and is deposited into the venule. And the arterial end is mostly filtering, so this is where fluid is being pushed out of the capillaries, while the venous end is reabsorbing. So here, fluid is being reabsorbed from the interstitium back into the capillaries. And under most circumstances, there's a nice balance between filtering out and reabsorbing back in most capillary beds. The hydrostatic pressure is just the pressure that's conveyed by the volume of blood in the vessel, so kind of like the blood pressure. And the hydrostatic pressure in most capillaries is high, so this gradient pushes fluid out or filters, so that this hydrostatic pressure is really the major driving force for fluid to leave the inside of the capillary. And as blood flows through the capillaries, the hydrostatic pressure declines, and that's because of the resistance that it's encountering within those capillaries. And colloid osmotic pressure or oncotic pressure is a force that opposes filtration, so it's involved in pulling fluid back into the capillary or reabsorbing fluid. And it's determined by the protein concentration, and remember the main plasma protein is albumin. And it's these pressure gradients that determine whether there's filtration or reabsorption. So on the arterial end, there's filtering out because the hydrostatic pressure gradient is greater than the colloid osmotic pressure gradient. While on the venous end, once the hydrostatic pressure has decreased, now there's reabsorption because the hydrostatic pressure gradient is less than the colloid osmotic pressure gradient. So the hydrostatic pressure and colloid osmotic pressures are referred to as Starling forces. And this is the Starling equation that takes into account each of these Starling forces to calculate the capillary filtration rate, or the rate of fluid movement across the capillary. And the filtration coefficient, or K sub F, is influenced by capillary permeability. So it's basically the water permeability of the capillary wall, and it depends on the type of capillary present. So, for example, continuous capillaries, like in the brain, aren't very permeable and they have a low filtration coefficient, while fenestrated capillaries, like in the kidneys, allow a lot of filtration and they have a high filtration coefficient. So this is the overall equation, but as we'll see, a couple of these forces contribute very little under normal circumstances. And so we can simplify the equation by removing those factors, and those are the interstitial hydrostatic pressure as well as the interstitial oncotic pressure. So now let's look at each of these factors individually. So first there is the capillary hydrostatic pressure. So this value is just the pressure of the fluid within the vessel, and it depends on a few factors, including mean arterial pressure, how much blood is flowing into the capillary, as well as the resistance. And it's probably the most important factor in capillary exchange. The capillary hydrostatic pressure favors filtration and pushing fluid out across the entire capillary, but this is the only force that actually varies from the arterial end to the venous end. The reason for this drop is the resistance inside of the capillary, and as the blood flows across this resistance, the capillary hydrostatic pressure is higher on the arterial end and lower on the venous end. Next, there's the interstitial hydrostatic pressure. And this is the tissue pressure, or the pressure outside the capillaries that opposes capillary filtration. So under normal circumstances, the interstitial hydrostatic pressure is close to zero, and so it really contributes minimally to capillary exchange. The factors that contribute to the hydrostatic pressure in the interstitium are the volume of the interstitial fluid as well as the distensibility of that interstitial space. And although normally the value is relatively low, if there was something like a lymphatic blockage preventing fluid drainage or increased capillary permeability leading to increased filtration, these are the types of circumstances that would lead to increased interstitial hydrostatic pressure. Now let's look at the osmotic forces, and first we'll look at the capillary colloid osmotic or oncotic pressure. And this is the component of the osmotic pressure that's contributed by plasma proteins, primarily albumin. And it's the most important pressure that opposes the hydrostatic pressure of the capillary that is trying to push that fluid out of the capillary. So this capillary colloid osmotic pressure is trying to pull that fluid back in, opposing filtration. This factor varies directly with plasma protein concentration. So if, for example, a patient had advanced liver failure and the liver wasn't making albumin to the same extent, the plasma protein concentration would be low, and therefore the capillary oncotic pressure would also be low, and that would lead to a decrease in reabsorption. And finally, there's interstitial colloid osmotic or oncotic pressure. And this is the osmotic pressure contributed by proteins outside of the capillary in the interstitial fluid. And since proteins are generally confined to being within the vessel, under normal circumstances, there aren't a lot of plasma proteins in the interstitium, and this value is very low and contributes very little to the filtration rate. If there was a circumstance where proteins were leaking out of the capillary and entering the interstitial fluid, the interstitial colloid osmotic pressure would increase, which would favor filtration and enhance the fluid filtration out of the capillaries. So now let's take a closer look at factors that can affect the Starling forces and therefore can affect the capillary filtration rate. So this is a simplified version of that Starling equation with the capillary filtration rate depending on the capillary permeability and the capillary surface area, as well as the difference between the capillary hydrostatic pressure and the capillary colloid osmotic pressure. So first we'll look at factors that influence capillary permeability and the capillary surface area, or the number of capillaries that have flow. So there are some inflammatory factors that can increase the capillary permeability and therefore increase the K sub F. The factors that influence capillary surface area are vasodilation and vasoconstriction. So at rest, not every capillary has flow at every point in time. So some of the arterioles are constricted, and as a result, the downstream capillaries aren't perfused. So if there's vasodilation, that would allow more flow to the capillaries, increasing capillary surface area. And vasoconstriction would do the opposite, decreasing the capillary surface area. So let's look at this example of local histamine release by mast cells and see how that affects filtration. So one thing histamine does is to cause release of local vasodilators to increase blood flow and increase capillary permeability and increase capillary surface area. And with large increases in capillary permeability, there's actually a filtration of plasma proteins from inside the capillary into the interstitial fluid, which would increase the interstitial colloid osmotic pressure. So when these things happen, that causes a large increase in the capillary filtration rate, which can lead to edema with swelling and welts. Now let's focus on the capillary hydrostatic pressure and how it can be affected. So the main determinant of the capillary hydrostatic pressure is the relative vasoconstriction of the arteriole. So increasing the resistance of the arteriole through vasoconstriction ultimately leads to a decrease in the pressure inside the capillaries. So blood flowing then across the arteriole with more resistance has a greater pressure drop. This means that by the time the blood gets to the beginning of the capillary, it has a lower pressure because the pressure was dissipated here across the arteriole upstream. This decrease in the capillary hydrostatic pressure can lead to a decrease in capillary filtration rate and an increase in reabsorption. The converse is also true, so if an arteriole is dilated and the resistance in the arteriole is decreased, that ultimately leads to an increase in the capillary hydrostatic pressure. So this then leads to an increase in filtration and a decrease in reabsorption. Any large changes in mean arterial pressure overall actually end up causing a relatively small change in the capillary hydrostatic pressure and the capillary filtration rate. And this is because there's that myogenic response in the arterioles that buffers large changes in mean arterial pressure. So this autoregulation that occurs ends up causing a rather small change in the hydrostatic pressure in the capillaries and the filtration rate. Now, if we look at changes in the venous pressure and the effect on the capillary hydrostatic pressure, it's a different story. So any change in venous pressure causes a large change in the capillary hydrostatic pressure and the capillary filtration. And that's because there's no venous myogenic response. So there's no autoregulation that occurs on this venous side. So that means that any increase in venous pressure causes a proportional change to the capillary hydrostatic pressure, and that can greatly affect the capillary filtration rate. So if there is any increase in the hydrostatic pressure in the veins, that translates to a large increase in the capillary hydrostatic pressure here, which results in a large increase in the capillary filtration rate. In these cases, the increased volume filtered can exceed the capacity of the lymphatic system, and that's what leads to this risk of edema.